Okay, let's discuss on the management of the first stage, second stage, and third stage of labor. Let's start with the first stage. The first stage is from os 4 cm to os fully. The common problem is labor dystocia. Labor dystocia is divided into three: poor progress, secondary arrest, and failed IOL. Poor progress is when the os do not progress more than 2 cm over 4 hours of labor after adequate contraction pain. Is usually caused by power. Secondary arrest, initially present of good progress, then arrest at more than 7 cm after 2 hours of labor. This usually caused by passage or passenger. Fail IOL, do not progress after IOL. This usually caused by shoulder dystocia. Here's the summary. Another summary. Okay, there are a few things to manage during first stage, a total of 9. Okay, first, plot pathogram. Number 2, do VE. Number 3, CTG after ARM. Number 4, hydration. Allow clear fluid only, 100 to 150 cc per hour. Normal patient, 2 cc per kg per hour. However, for PE patient, preeclampsia, 1 cc per kg per hour. This is because the PE, the patient has proteinuria, and there's also risk of acute pulmonary edema, APO. To assess hydration status, we look at the urine ketone, and you can breathe the ketonic breath. Analgesic, there are 4 types: parenteral, epidural, combined spinal epidural, and an inhalation. For parenteral, there are 3 types of parenteral given usually. Pethidine 75 mg or 1 mg per kg plus Phenergen 25 mg. This is the Phenergen is to avoid vomiting. Tramal 50 mg to 100 mg. Nubane 100 mg. There is also epidural, combined spinal epidural, and inhalation, which we usually give Antonox, and 50% or 50%. We should do vital signs monitoring hourly. Glucometer, complete blood sugar hourly. If she's on insulin, start the insulin sliding scale or DIK regime, which is the dextrose 5% plus insulin 5 unit plus potassium. Next, we should do next review contraction every 2 hours to monitor the pitocin augmentation. We would like to aim in primate, we aim 4 in 10. Multi, we aim 3 in 10. Just extra about pitocin. Pitocin is a synthetic oxytocin. It's used for induction, augmentation, prophylactic postpartum hemorrhage, and treatment of the postpartum hemorrhage. And lastly, what we should manage in the first stage is to do intermittent CTG tracing. Management of the second stage, the usual problem would be shoulder dystocia, perineal injury, and prolonged second stage or obstruct labor. Second stage is when the os is fully until the delivery of the baby. In practice, we allow primary gravida maximum 1 hour, multi 30 minutes. However, according to guideline, if without epidural, primary 2 hours maximum. If with epidural, 4 hours maximum. If multi, without epidural, 1 hour maximum. With epidural, 2 hour maximum. Management during a second stage. First, encourage to guide to bear down. Empty the bladder before VE. CTG monitoring and vital sign monitoring. The second stage can be active or passive. Active if it is expulsive, passive it is propulsive. Before VE, how do we know that patient is already full? Is when the patient tak rasa nak terrun, anus dah terbuka, is already relaxed and maybe terkeluar berak. Okay, prolonged second stage is after OS is full after 45 minutes. They still don't deliver, so we call the MO. And also suspicious CTG, we call MO also. The management for third stage of labor, there are 4. The usual problem is PPH. Third stage of labor is when the delivery of placenta. First, you have to give the uterotonic medication, IM symptometrin, which contains 0.5 ergot plus 5 unit pitocin. It is contraindicated in patients with heart disease or hypertension. This patient should be given IM syntocinon, which is the pitocin, 5 to 10 unit. Okay, 1 vial is equals to 1 ml or 10 unit. Then number 2, do early cord clamping. Number 3, CCT. Number 4, uterine massage to prevent PPH. Placenta delivery, maximum duration 1 hour. We should alert MO after 30 minutes. After 1 hour, MO should do the manual removal of placenta, MRP in the OT. Should catheterize the bladder and inject intra-umbilical pitocin.